is Eleana Frisira, and this video is on Neuroleptic Malignant Syndrome and Serotonin Syndrome. The contents for today's video are we're going to have a case presentation, discuss the presenting features of Neuroleptic Malignant Syndrome, the causes and the management, and then we'll discuss a case presentation of Serotonin Syndrome and the causes of the management of that. We'll finish with a practice question and then wrap up in a summary. So let's start with the first clinical case. You're on the psychiatric ward. Gary is a 28-year-old male admitted 4 days ago for management of his first episode of psychosis. He's receiving depot-IM injections of aripiprazole. This morning you notice he started to behave oddly. He's confused and has become urine incontinent. On examination, widespread muscle rigidity. These are the observations for your patient Gary. So let's try and identify what's going on in terms of presenting features, what clues we have to understand what's going on. So first of all, Gary's confused and we know he's become incontinent of urine. There's also widespread muscle rigidity, and looking at his observations, he's lightly tachycardic, he's tachypneic, his blood pressure is elevated with a systolic of 166 over 98. And he's responsive to voice, which is in line with his confusion, and his temperature is 39.6, so he's pyrexic. What background information do we have for Gary? The important things are he was admitted 4 days ago, he's in hospital because of psychosis, and he's receiving depot-IM injections of aripiprazole. Aripiprazole, for those of you that are not very familiar with drug names in psychiatry, is one of the newer generations of antipsychotics we use. So this is a sort of typical presentation of neuroleptic malignant syndrome. Let's try and break down the features that we saw in this patient, Gary. So he was confused, and confusion, agitation and anxiety are all in that spectrum, the umbrella term of altered mental status. And patients can present with either of these depending on how severe it is. Hypothermia is another very, very cardinal feature. Muscle rigidity, or in more severe cases, rhabdomyolysis, or further in the course of the condition, patients can go into rhabdomyolysis, which is characterized by muscle breakdown and myoglobin accumulation that can be nephrotoxic. So an important investigation would be to do a creatinine kinase to know if this is going on, and then autonomic instability. This again is a big umbrella term. It can manifest in many different ways. Examples would be, this is not an exhaustive list, tachycardia, tachypnea, blood pressure disturbances, either hyper or hypo, incontinence or retention, diaphoresis, which is the fancy name for excessive sweating, and sialorrhea, which is again the medical term for excessive saliva production. So some of these were present in Gary. The pathophysiology for neuroleptic malignant syndrome is not very clear, but what the theory is, what we know, is that dopamine is the main neurotransmitter that's involved in what's triggering this condition. And that makes sense because dopamine is a neurotransmitter that's very abundant and very important in many different parts of the brain, either cortical or subcortical. For example, in the striatum, which is more responsible for movement, this is where you get the muscle rigidity from. When you get dopamine imbalances, or when you get dopamine imbalances in the hypothalamus, that's when you get problems with thermoregulation, among other things, and you get hypothermia. And that all triggers an autonomic dysfunction where your body cannot balance between find a fine balance between your sympathetic and your parasympathetic nervous system. So the causes of neuroleptic malignant syndrome are mainly medications that mess with the dopamine in your brain, and antipsychotics are very much involved with dopamine, and either the first generation like chlorpromazine or prochlorperazine, or the second generation ones like aripiprazole in Gary's case. All of them are a very common cause in neuroleptic malignant syndrome patients. Now, withdrawing Parkinson's medications Again, we know that Parkinson's medications provide dopamine to um, Parkinson's patients, so withdrawing the source of dopamine limits the availability of dopamine, again causing an imbalance. So this can be a trigger. And then lithium and anticholinergic agents, although have less of a clear pathophysiology link, are also known to be triggers. Talking about management, it's important to transfer to the medics if this is diagnosed in the psychiatric setting, like it was in this case. In acute behavioral disturbance, agitation that can regress to aggression, benzodiazepines can be helpful to facilitate further management. You need to stop any causative agents like antipsychotics that you're giving, depot injections, IM injections are particularly high risk. Or in case it's a withdrawal of a Parkinson's medication, you might need to restart it to stop that syndrome. Supportive medical therapy is particularly important. You need to help patient with thermoregulation, cooling blankets, cooled fluids, blood pressure control. And if the patient is in rhabdomyolysis, you need to vigorously hydrate to prevent renal injury because of this toxic accumulation of myoglobin. If rigidity is very severe, you can give medications like dantrolene, which is a postsynaptic muscle relaxant, because this is very uncomfortable for the patient and you really need to help them. Moving on to our second case, we're in A&E now. 23-year-old female Amber is brought in by a friend. She's confused, shivering and unsteady on her feet. Her friend tells you they have been out partying and have tried amphetamines for the first time. Amber is also on high-dose antidepressants prescribed at her GP. She does not take any other medications or have any previous history. On examination, there's widespread rigidity and hyperreflexia of the lower limbs, and the observations are as follows. So again, let's do the same and identify the main presenting features. Amber is confused, shivering and unsteady, muscle rigidity, and hyperreflexia of the lower limbs. This is probably something new from what we're used to. In terms of observation, she's tachycardic again, tachypneic, and she also has a temperature of 40.2 that makes her pyrexic. The background in this case is very different from Gary, so she's used amphetamines today for the first time, and we also know that she's on high-dose antidepressants. So even though most of the presenting features that we saw were quite similar between Gary and Amber, the background context that we have is very different. And this background context screams serotonin syndrome to us. So let's talk about serotonin syndrome. The features of it are confusion, agitation, anxiety, again this umbrella of altered mental status, hyperthermia, rigidity of the muscles, rhabdomyolysis in severe cases, clonus, hyperreflexia, which is a hyperkinetic response, and autonomic dysregulation, which again can manifest in many different ways. We can see that most of them are quite similar. The only one that stands out from the list of neuroleptic malignant syndrome features that we have is the clonus and the hyperreflexia, and this can be a feature that points towards serotonin syndrome and helps us differentiate. Now, talking about the causes of serotonin syndrome, it's obvious that serotonin is the main neurotransmitter here, and so causes are medications that mess with serotonin, SSRIs, the most common cause because they're very commonly prescribed, other antidepressants, SNRIs, TCAs, MAO inhibitors, and then recreational medications like amphetamines or LSD, over-the-counter drugs like St. John's wort, lithium, again, can be either or, and then triptans, which are used in the management of migraines, can also predispose to serotonin syndrome. We have a table that can help us differentiate between the two. In terms of etiology, we've said that NMS is mainly because of antipsychotics, and it's important to remember that this can be caused even if we have antipsychotics in therapeutic doses. While with serotonin syndrome, serotonergic agents in normal therapeutic doses in isolation usually do not cause serotonin syndrome. There needs to be a combination of medications that mess with serotonin, so 2 or more. In this case, it was amphetamines with the SSRIs, or it would be an overdose. The onset is slow with NMS. It took 4 days for Gary. It could be longer, it's usually days, it could be even a few weeks, while with serotonergic syndrome it develops within a few hours. In terms of symptoms, we've talked about how NMS has very severe rigidity and bradykinesia, which reminds us of the Parkinsonian symptoms because it has to do with dopamine imbalance, while serotonergic syndrome prominently hyperkinesia, hyperreflexia. So the management for serotonin syndrome, if there's an overdose related presentation, consider activated charcoal if it's within an hour or depending on the local poisoning guidelines, and contact the psychiatric team. Remember to be empathetic, don't get overwhelmed by all the medical things that are going on. There might be a lot of things going on in the head of that patient. Supportive medical therapy similar to NMS, benzodiazepine again for behavioral disturbance. If there's a seizure going on because it's a severe case, benzos are used to treat seizures, and cloners can also be relieved by benzos. Rhabdomyolysis, remember to hydrate to prevent renal injury, it's really important. And then in some cases, chlorpromazine and 5-HT receptor antagonists can be used, although it's more of a senior decision. But remember it for SBAs in exams. Practice question, have a few options. NMS has a rapid onset, while serotonin syndrome has a slower onset and course. Measuring creatine kinase levels is important in serotonin syndrome, but not in neuroleptic malignant syndrome. Combinations of prescribed and over-the-counter drugs are more likely to predispose to serotonin syndrome rather than neuroleptic malignant syndrome. Benzos can be used for neuroleptic malignant syndrome, but not for serotonin syndrome, as they can cause the patient to deteriorate. Which of the following best describes the differences between NMS and SS? So the right answer here would be combinations of prescribed and over-the-counter drugs more likely to predispose to serotonin syndrome. Over-the-counter meds, recreational drugs, prescribed antidepressants, all these can interact. The patient wouldn't know, and this is a common cause of serotonin syndrome together with overdoses. In summary, we've talked about NMS and SS, two important emergencies in the psychiatric setting, present very similarly. Some hyperkinesia and hyperreflexia can be a way to differentiate if that's part of the presenting syndrome, but prompt diagnosis and treatment, mainly supportive treatment, can be life-saving. So these are the references for this presentation. Please subscribe to the channel for more teaching videos if you found this useful, and fill in the feedback form below. Thank you so much, and you can leave any questions in the comments.